Today we are going to discuss about the topic ICU alarms, fatigue and burnout. ICU alarms is something which as nursing officers you face it directly and always when you're on the bedside. So it is very essential to address the alarms and how it has to be done and when it has to be escalated because eventually you are the ones who are going to inform the doctor. And many times you would have realized during sleep also you get to hear the alarms and all that. That's basically what shows what is leading to fatigue, and the most severe form is burnout. And to talk about this topic, we have Dr. Jeetendra Sharma sir, who is the Chief of Critical Care and Chief Medical Quality Artemis Hospitals. And along with that, he's the Secretary of Nursing, Indian College of Critical Care Medicine. So all the topics that were designed in the last year were done under his guidance. And at the end of the class, we can always have a suggestion from your side. And I would definitely want to put stress on this fact. The beauty of Sir's lectures are how he simplifies things and makes complicated things appear very easy. So prepare yourself for a lovely lecture. Sir, all yours.
Thank you, Dr. Shakya, for kind introduction and rolling the ball for our today's topic, ICU alarm, fatigue, and burnout. I covered this whole topic into the three segments. To begin with, an ICU alarm, in fact, we are using so many devices, and especially monitor is the integral part of ICU care. And the next one is the ventilator. So these two are the very, very integrated devices which we are using in ICU, and the alarm related to these devices all the time we are hearing. So we need, in this lecture, I would cover a little bit basics of the alarm and how to manage in terms of the overall processes of the alarm. Not each and every individual clinical setting I will talk. I'll give you an overview and the understand why I feel this. There are the two reasons why I selected this topic and the ICU alarm. Point number one, I realize we are underutilizing our devices and inappropriately response or not responding to the alarms, and sometimes the alarm fatigue also, which at this moment most of the Indian ICUs require understanding of the ICU alarm, especially the bedside nurse and the overall nursing team, as well as the other supporting team like ICU technicians or dialysis technicians, all these things. And finally, in this lecture, I will little bit address about the role of leadership for this particular topic. What is their role? What is their responsibility? And how they are going to help the system to build the system which will ensure the safety as well as the free the system from the alarm fatigue. So to begin with our topic, ICU alarm, first is the definition in general alarm. An alarm is the warning that result from measurement variance. So whenever we measure something, if there is deviation, that will be indicated by the, we'll see how it is going to indicate in the form of the some sound will be there or some display would be there. Alarm are the essential and necessary monitoring, especially when we talk about the vital monitoring. Of course, all and each device will have alarm. I'll discuss a little bit into that. But as we know, whenever we use any device, the alarm is integral. Now, even in our when we are driving the car, if we are not put on the our seat belt, there would be alarm for that. So there is always some kind of a safety feature. Whenever you use any device, the alarm would be there. And the alarm indicates call for immediate action or defense. So to introduce the topic in our sense, in our clinical practice, the monitoring system are intended to increase patient safety. The intention is the patient safety in the hospital setting by quickly alerting caregivers to patients' distress, thereby facilitating Here are the two important keywords: timely response and timely action. So a response in terms of what is whenever the alarm would be there would be a two steps approach to the alarm. One is somebody should respond it. Every response may not be necessarily followed by action. So first is the response, how fast and what action is required, and that too should be a time bound. Much of the equipment, including monitors, ventilators, intravenous infusion pumps, syringe pumps, which are used in the ICU, will give alarms and alert for various reasons. We know some of these alarms are essential to maintain patient and staff safety. But as we know, all of these alarms and alerts do not always require action by the caregiver. So here we will coin the term actionable alarm. The constant beeping, if the alarm is not actionable, but still it will be alarming in terms of some sound, so it will produce a overburdens of would be noise, sound would be there, and of course there would be information. Sometimes this information is not actionable, but there will be overburdens of the abundant information transmitted by the medical device, and they may not be actionable. That will create a alarm fatigue, and that put the hospital as well as the patient at a serious risk. What I mean to say, one hand, the alarm is devised for the safety, another hand, it is just creating the trouble for the caregiver. It actually polluting the ICU environment in the form of noise pollution, and that is called the alarm fatigue. Clinical alarm systems are intended to alert caregivers of potential problems, but if they are not properly managed, they can compromise patient safety. There are several underlying issues associated with alarm management that can increase the risk of patient safety. Issues associated with the alarm management include too many devices with alarm, default setting. Here I use the word the default setting. If our colleague is not really very much clear about this term, default means manufacturer themselves, they make the boundaries or certain values for the alarming. That would be a device specific. If we shut down the device, and on the device, alarm would be set on those settings which manufacturer keep the boundary, keep the threshold for that, irrespective to the inter-individual variation. That is called default setting. And default setting would be your device specific, not the patient specific. And this is not tailored by the patient condition. Say, for example, if we are using the monitor for the adult patient, possibly manufacturer set the default setting of heart rate 50 lower threshold and 120 upper threshold. But same device, if we are using for the pediatric patient who is having a baseline heart rate is 120, it will alarm all the time, and that is the normal for that patient, that particular age group. So here, that's why the default setting doesn't work all the time. This screen you can see. What I mean to say with this screen, you can see there are so many parameters displayed on the monitor, like ECG in the form of the rhythm, in the form of rate, arterial blood pressure, again the waveform as well as the value, PA pressure waveform as well as the value, CVP waveform as well as the value, SpO2 waveform as well as the value, EtCO2, and sometimes the airway pressure if it is integrated with this monitor. So there are so many things over there. Sometimes you want to see the just value. Probably alarm is not very much useful for you, but still it will alarm. And certain things you want to keep the alarm all the time. So whenever there are so many parameters is going on and the alarm is all the time over there, probably doesn't require the action that has all the propensity to create a noisy environment as well as the alarm fatigue to the caregivers. So that is the theme for this topic. Now you can see in your screen again the two example of the monitor, left side and the right side. You can see there are the some information is display on the top of the screen. On the left side, you can see the NIBP low and ventricular fibrillation or slash tachycardia, and the background color coding is the yellow and red. Another right side, you can see three messages are displayed. One under the blue background, second is the yellow background, and third is the red background. All are alarms. So what does it mean? Let's see. So alarm, if we want to categorize, there are the various way to categorization of the alarm, but broadly, which is very meaningful as to is the one is the visual and audio visual. Visual means you will see something is there. Audio visual is there would be information as well as sound will be there. That is the one aspect of the categorizations. Another aspect is the high priority, intermediate priority, and low priority. If you pay attention to these box, I written the high priority in the background fill of the red kind of this. Intermediate priority orange and low priority is blue one. That is not always universal all the time, but red and yellow almost always universal, but it may vary from one device to another device. So how you can categorize in the different priority? One, making the background red, as well as your sound may differ in terms of their intensity, in terms of their frequency. So both the way you can divide it. What do you mean by low priority? Low priority is some suggestion, may not be putting the patient at risk immediately. Say, for example, if ECG electrode is disconnected, SpO2 probe is disconnected, so alarm would be there. And probably sound character would be different also. When I showed you a previous slide in the monitor, say, for example, Philips, most of the ICU use the Philips, there would be just beep sound only. You will listen just beep and the information in the blue background, like a disconnected electrode or probe is disconnected. So it is not putting the patient at risk, but it gives you information. And probably sometimes you don't want to put it also. So it's up to you. Suggestive. Intermediate priority has these information has some propensity to harm the patient in few seconds to minutes, or may not harm depending upon your clinical situation. But sometime it may harm, sometime it may not harm depending upon the patient. Say, for example, 90 systolic pressure. 90 systolic pressure is harmful to those who are having the blood pressure of 140/70. Those who are having a blood pressure, low ejection fraction patient, and their baseline blood pressure is 95, 92 only, then 90 may not be there that much alarm. So that's why there is not certainty. They may be a life-threatening to one, there may not be another. So it would be given as the intermediate priority, and you will hear the sound. High priority, irrespective to the patient, it is always endangered to the life with the time bond. Not only endangered, the time bond. Intermediate priority gives you some time kind of this thing. Probably 90 is there, you can accept, you can respond, and all these things, maybe a few seconds to a minute kind of But high priority probably you are not having in the form of the required action in the fraction of the seconds. May or may not be possible. Say, for example, disconnected ventilator is the highest priority. A VF, highest priority. So, and that sound would be a different over there. So that is the another category. Another category, which if with this background of the question is equipment used in the ICU and hospital are having technical alarm, clinical alarm, A and B both, or no alarm. Anybody would like to give the answer for that? They can write in the chat box.
Sir, I'm keeping an eye on the chat box. If any answer comes in, I'll let you know.
Okay, so when we'll discuss. Meanwhile, I can find somebody raise the hand. You see, not really. So alarm can be technical and clinical. And in this, we will talk about the clinical more focused. What do you mean by technical and clinical? Say, for example, monitor is working on the power backup battery. So there would be alarm, but it will be a technical kind of thing. If patient is not at risk, it is related to the equipment management, equipment maintenance. That would be a technical alarm. Of course, it is useful, but now onward, from this slide or onward, we will restrict our discussion to the clinical alarm which we're talking about. The clinical alarm is actually equipment meant for the certain monitoring or management related to the patient care, and the whatever value or parameter or information is derived between device and patient interaction has some kind of a alert giving mechanism. This is called clinical alarm. Had definitely patient participation would be there directly or indirectly. Either there is a problem in the patient, that's why monitor or your device is capturing, or suppose your device is the actually therapeutic. Monitoring is the not therapeutic, like ventilator is therapeutic, and it causing some problem in the machine, which may potentially put the risk to the patient. That is also over there, and that is the clinical alarm. So clinical alarm, the recurrent noise from improperly managed alarm tend to, now what is the problem? The clinical alarm, if all the time it is ringing, then it desensitizes to the caregiver. Or if you may completely shut off the alarm, or you ignore, then there would be a problem. So therefore, it is important for hospital to understand its own situation and to develop a systematic coordinated approach to clinical alarm system management. So subsequent slide will talk about how you actually manage and the guidance. And these slides are based upon the JCI. They created a new standard under the care of patient COP chapter that addresses whatever devices you are using in the clinical practice. I repeat, all the devices. Of course, ICU, non-ICU also. ICU, emergency and OT. We are actually surrounded by so many devices. Therefore, this standard is very much relevant to us. And they guide organization and healthcare worker how to approach. The principle behind the management of the alarm is the keep the balance between these two important aspects. One, missed alarm. Missed alarm, either you disabled or ignore or didn't listen it, or you put a irrelevant threshold for that. Say, for example, you keep the low heart rate pressure limit as a 20. So it is irrelevant or more dangerous. other aspect, say for example, patient is in the atrial fibrillation or some systemic disease which is causing heart rate all the time 140, and you are keeping your upper limit 120. You know there is a problem, you are solving it, but it will take some time and may not be able to solve it because of underlying condition of the patient. You understand each and everything, but you didn't change the alarm limit. Now every time 120 heart rate crossing, all the time it is alarming and you ignore that alarm. And suppose over the time period some other alarms comes, then you think this is the high rate alarms only and you miss that event. Even if you are visualizing all the time, you can say we are having a 1:1 nurse, all the time it is there, so we don't have a problem. We'll not miss the other alarm. May or may not be possible. Again, we'll take it. But all the time this ringing, this belling sound, this alarming sound make the alarm fatigue, and the human brain conditioned to that alarm, which in the form of the noise. Then your system, your assigners, your rest of the team member in the ICU, all these things get desensitized. Even they listen it, they think it is these alarm. Like we have seen so many ICU all the time ventilator is alarming. Nobody pay attention over there. They take it as it is a norm of the ICU. The ICU should have all the time is alarming. That is the usual Indian ICU, but technically there should not be any ongoing alarm in ICU. So alarm fatigue is another one. So what needs to be done? So this is the slide actually guiding the hospital management system, how to help the overall complete hospital healthcare worker in the system who are using the device more relevant to our ICU. First is establish alarm management as an organization priority. You should make the rules of game according to your particular unit. First, note it down. Identify the most important alarm to manage based upon the internal situation. You decide. There are certain things you can't afford. Say, for example, vital derangement, you can't afford, you can disable it. So, heart rate, of course, you have to take into the account. Whether will you use the respiratory rate as an alarm or not, depending upon the situation. If you are having a 1:1, most of the patient on the ventilator, so they are already having a displacer, then you can disable that respiratory rate alarm. Suppose if it is a HDU kind of this thing, not 1:1, then you want to keep the respiratory rate alarm. So that's why the second point is according to your need. Temperature, probably you don't need the alarm, but those patients who are requiring a target temperature over there all the time, then you need that alarm. So that's why there may be conditions where you can actually keep the alarm on or keep the alarm disabled. Seek input from the medical staff and clinical department. What does it say? When you are making your rules of game, I'm using the word your rules of game to understand the our document. Technically, it is like a policy and SOP. So when you are making the policy and SOP, then you have to take those person in account who are actually using the devices. What I mean to say, some other, maybe a remote quality department or medical superintendent or any other who is not coming to the ICU, who's never saw the ICU, should not make the alarm policy of the ICU. Or ICU person should not make the alarm policy of the OT. Better you discuss with those persons who are managing the devices and what they think. These are the alarm for our patient safety, and these are the alarm are unactionable alarm which has tendency to produce alarm fatigue. Identify risk to the patient due to lack of response and malfunction. Identify actionable alarm versus alarm contribute to the noise fatigue. And proactively identify potential for patient harm based on the internal incident history. So not only you make, and over the time period you can keep your eye if something wrong happen, if unintentional harm happened to the patient, go back and try to see whether your alarm policy could prevent this harm or not, so that you can revise your alarm policy and you can actually publish this. Hospitals are expected to develop and implement a specific component of policy and procedure that address at minimum. So previous slide actually showed an overview of this thing, but what exactly this policy should include: clinical appropriate setting, when alarm to be disabled, when parameter can be changed. There is a difference between disablement and the parameter. When I say the word parameter is changed, change from default setting or change from the previous setting. Who can set, who can change or turn off parameter, process for monitoring alarm and expectation moving forward. This point actually meant for not only you make over the time period, you keep on reviewing your process. Whether your alarm policy is too relaxed means you included so many alarms, then probably it will more alarm fatigue, or you make us too tight, only the few alarms are you make enabled and all these things, probably you miss the event over there. So depending upon the situation, you keep on making your effort to see the how your policy is working for your unit. Checking individual alarm signals for accurate setting, proper operation and detectability. Not only this thing is your policy, you try to see whether whenever the alarm is there, it is actually the things are happening or not. When your ventilator is showing the leak alarm, it is actually leak or not. Or when there is a leak, it is actually alarming or not. So in between, you see and educate. Everybody must know what needs to be done, what are the alarms that they need to respond it, what time frame, and what needs to be done, and who can handle the alarm. So ultimately, by making you just want to say acknowledge notification, assess the patients, which alarm require immediate patient assessment, which alarm requires the your situation assessment or device management. So all these things important, and educate. This is the example of our hospital policy. I'll not expect everybody to read this thing, is this whole document. Only pay attention to the upper part of the main heading. Say for example, type of equipment is written here, like a patient monitor or ventilator. What are the clinically appropriate setting for alarm signals? So these all are the clinical alarm. These are not the technical alarm. Technical alarm would be your battery low, your expiratory valve requires some servicing. All these things is a technical alarm. Who has the authority to set default alarm parameters? So manufacturer, so that nobody can actually default can change. When should alarm parameter be changed? There has to be written out there. When can be changed? Who can acknowledge the alarm? One is the word acknowledge, and second is the authority to the change parameter. When should alarm parameter be disabled? So this is the a typical policy over there. In your clinical way, where the most a dangerous alarm is there, then you can make your internal flow. Say for example, if you find a highest priority alarm from monitor, so immediately assigned staff or nearby staff immediately go and check the vitals and the patient safety first, then go to the monitor. Same way ventilator. So all these things, this is just snapshot over there, but you need to know the clinical alarm, device, condition, as well as what needs to be done, what action required. So this question, people should participate to give the answer. In ICU, if ventilator is alarming, what should you do? Silent or disable the alarm? Call doctor immediately? Call biomedical engineer or respiratory therapist? Ensure patient safety first.
You can put your answers on the chat box.
So at this stage, if anybody is having any other confusion related to alarm, they can put this thing simultaneously in the chat box and we'll cover it, because now onward we'll we'll move to our next segment, that is the ICU fatigue. So till now, I covered the alarms. So I think most of the people, I'm sure know the answer, but a little bit hesitant to put in the chat box. So technically, as I told you, ventilator is a very prime device, and whenever there's alarming, then you ensure the patient safety first and then go for the device. Now, ICU fatigue. The ICU fatigue, this more relevant to the nurses and this maybe a technicians over there. A very brief kind of understanding what are the factors for the ICU fatigue and how it actually turns out to be in the practice. So till now we covered the ICU alarm. If anybody is having anything in their mind, please type in the chat box related to the alarm segment. Of course, we'll take it in the end of this thing. Is till you forget, you can write your query or question or anything you want to interact with us. ICU fatigue. One hand, your patient safety. We talked about that. Now, another kind of this thing is caregiver and what factor contribute to the ICU fatigue specific to the ICU environment. So when we thought about one is the fatigue is actually your a bodily fatigue. If somebody is fatigued, then definitely he'll be fatigued during the ICU work. Emotional strain, long shifts and overtimes, high patient equity, workplace environment, physical demand. I'll touch a little bit of workplace environment in one aspect. Physical demands, staff shortage. These are the common factors, prime factors which we can say is directly related to the ICU fatigue. Other few factors may contribute to this. Psychological status is purely performer. If they are a little bit low in their psychological state, whatever they are exposed, they will feel fatigue. We see in our common day-to-day life. If we're very much pro and enthusiastic, the same work will not feel as a burden for us. So we keep on doing. Work organization sometime would be there. Say, for example, somebody is more trained in some area and they are posted in another area or whatever. There may be so many reasons, technical or personal, and all these things may lifestyle, lack of control over one environment, insufficient reward. People doing and don't get any reward. A general breakdown in the work community. In general, people say this actually nature of job is very not up to the mark, and all these things may contribute to the fatigue. And the emotional strain and environment. Sometime you may encounter the VIP patient that apart from your all I mentioned in the previous slide, the more contribute your fatigue and irritation. This is the unique to the R scenario and R system over there. So this thing will not be mentioned in the Western country literature, but we may encounter. And if this VIP is toxic in nature, then you are completely burst out. Not only produce the fatigue, it will give you a burnout also. Can you measure the fatigue? Is it a qualitative word only, or somebody can measure it? Yes, one can measure it on the score 0 to 10. Of course, it would be a subjective, but it is measurable. Once somebody's ICU fatigue is there, what consequences happens? Here the fatigues involves bodily as well as the psychologically. Eventually, your performance get affected. So what happens? Decreased job satisfaction. Patient is also at risk, and eventually it will make the ground for burnout. So subsequent section, I'll discuss about the burnout, which is actually starts from the ICU fatigue. So ICU fatigue to the burnout. So why I included all this chapter in the one? So from the patient centric, we started from the alarms. So in your professional obligation, if you manage the alarm appropriately, then there may be less chances of your ICU fatigue. So whatever we mentioned, the factor or this thing is, I'll not say just somebody can argue or this by listening this talk. It appears to be if we manage the alarm very well, our life will be excellent in the ICU. No, I'm not saying that. But one of the important thing, which is your patient management from keep them safe as well as alarm fatigue, that would be a one aspect. And from where I link over there, the one of the contributor, the ICU fatigue, and ICU fatigue leads to this, and then we'll discuss about the burnout. So what could be a potential solution at this moment? So please be with me from here to the subsequent section. So the ICU fatigue is a very, very earlier part over there. So what potential solution, what you can do is adequate staffing is the one that is most important. Education and training. When you are educated about the things and you are trained your work, then your stress goes down. I am always giving the example of my colleagues. Say, for example, if some doctor newly joined, and if he will be called somewhere else, usually we see the most of the people avoid that call to attend. What is the reason behind that? Are they really lazy person, or they are unprofessional, or they don't want to do work? No. The problem is this: they newly entered into the system. They don't know if they go over there, what they understand the patient or not, what they will do for that patient. Vis-a-vis, if somebody train and get the call, they immediately jump and go over there because their mind is already trained for that particular work. Then they will go, then they apply their knowledge and skill, and then they do action accordingly what is required. So most common for the avoidance of work as well as the stress is you are not adequately and appropriately trained in your work which you are doing. Just getting the appropriate education and training will reduce the sometimes workplace changes. As I told you, the fatigue is not the absolute, it is a relative. Same work for A person may not be fatigue enjoyable, the B person may feel it is a fatigue. So if it is an individual kind of this thing, then workplace change can be. And mental and health support. As I told you, sometimes your fatigue is perception in the mind, actual and sometimes perception. So all these are the four major pillars which we can use to manage the ICU fatigue in the healthcare giver, especially the nurses. So adequate staffing, education training, mental and health support, and obviously workplace changes, especially which is not actually coping it up. So that we'll discuss in the burnout. So again, the question is all are contributes to the ICU fatigue except if somebody know the answer, they can type in the chat box ABCD. The question means all are contribute the things which does not contribute. So contribute ICU sick patient having multiple organs support. Does it contribute to fatigue or not? Yes, because as under the heading as we discussed, the high acuity. Long shift, yes, it contributes. Non-communicative ICU patient, staff shortage, Non-community ICU patient is not really risk factor for the ICU fatigue. In fact, sometimes it is good to not to have a communicative patient. So we completed the second segment. Now we are moving to the last and final segment of this talk. It is ICU burnout. Still, if somebody is having, they can type in the chat box related to the first two segments. One is the alarm management policy, and second is the burnout. ICU fatigue. Now, ICU burnout is basically a extension of your problem from ICU fatigue. So you can see the things are intact and gradually fatigue, and finally it's the burnout. So how do you really define it? Just fatigue, chronic fatigue, stress in ICU is not equal to the burnout. Burnout is a very, very specific syndrome, conceptualized resulting in chronic workplace stress that is not successfully managed. We'll discuss subsequent in the slide. So whenever you use the word burnout, it should be used appropriately, because burnout is a very, very advanced stage of the things start from the ICU fatigue to stress and then the chronic fatigue. So it's not the simple ICU fatigue. When your ICU fatigue is a reversible condition. You given the break, the things will be better. You work on the education training, the staff adequate, then the ICU fatigue will be reversed. It's not the a permanent situation or irreversible. ICU fatigue to the burnout is going to be affected all the time over there. And this is the principle. Your like it's raining is there, you are having umbrella and simultaneously umbrella is not working. So both the way, your you can say whatever risk or whatever offending agent is high in magnitude, and your defensive services is also faulty. So one thing is external environment is so much stressful, and your internal environment is not able to cope it up. When this thing happens simultaneously to the very, very high magnitude, then the burnout happens. Why I'm giving you this pictorial as well as because we know whenever this happens, then you have to work on the both the side, your internal environment, your external environment. Then only one can come out from the burnout. So by WHO, it is defined as when you really call this the burnout, it's an increased exhaustion or fatigue from job. That is the ICU fatigue. Now the second and third important point: increased distance from career or having negative thoughts toward the career, and decrease in professional productivity. So now you trap in the vicious cycle. So exhaustion, inefficiency, and cynicism. Exhaustion means it's really you feel all the time tired. अरे थक अब नहीं होता है, ये इतना डिफिकल्ट पेशेंट, इतने सारे काम नहीं होता मेरे से. Exhaustion. Inefficiency means normally anybody can do it. अगर you have to load the medicine within a few seconds. If crisis happens, then you have to fill the 50 ml syringe, which anytime it takes a few seconds. But you are not able to, you gradually taking the slide, your syringe, searching for the needles, which you already organize, and all these things. This is an example of inefficiency. And cynicism is, you think this work is a completely damn work I am doing. Better to go into the OPD over there. OPD actually, till now, OPD don't work in the night, so there will be no night. Just I am seeing over there all the time, little bit reasonably stable patients, sometimes happy faces also, and I get the reward in the form of the whatever I am helping to the patients. Here the patients are unconscious and all this thing, whatever I'm doing, probably they may not be able to appreciate my effort, and patient is so much sick, even they may not survive to appreciate my efforts. So all the negative things can come, and when it's combined, then only you can call it as a burnout. So one can really gauge into it. If these things happens, so then you have to, earlier action is required from this thing. Next 2-3 slides gives you idea about, because there are so many friends among us. Probably my thing, yes, similar thing I noticed in some my A colleague, B colleague, or in myself, or sometime, not all the time. And it's a problem from the my side only, or is it a problem of the hospital, or it is a problem of the my supervisor, or it is a problem of the my team leader, all these things. If I change the hospital, everything goes right. So these data actually from the US in the form of survey in the US, where everything is very well defined, then still it is the problem. The aim of these slides is to giving you idea. There is there is problem existing in the systems, and we need to understand. So they reported 1 in 3 nurses report spending excessive time working in the electronic health record. So we are moving towards the paper-free digital world, HIS, electronic record, but it is counterproductive. And the survey showed 1 out of 3. 1 out of 3 is a very, very large percentage, 33%. So they show it is excessive. Nurse mental health outcomes, self-reported burnout. As I told you, burnout, and the people say, oh, I feel I am burnout from the nurses. 47% of the hospital nurse, I'm not talking about the ICU nurse, 47% of the hospital nurse and 32% of the hospital physicians. Nurse mental health outcome, female nurse suicidality. Very, very alarming numbers. 99, please take it as a careful, 99% is not thinking of the nurse. 99% more risk. That means if general population is having a 1 risk, then the nurse will have a 2 times risk for the suicidal thought. Whereas physician is having a 70%. When we say 100%, it's a double risk. The physician is having a less than double risk for the suicidal thought. 18% of registered nurse leave the profession within 1 year. 18%. If the 100 nurse, fresh, young nurses join the nurses after the completion of their training, they join the nursing profession. Within a year, 18% nurse actually change their profession. I'm not saying workplace, profession changes. So these were the alarming data from the one survey published in the 2014. And this one is 2021 suicidality, and your 23 self-reported burnout, very recent one. So this gives you an idea about what I am talking makes some sense. Working in the hospital as well as in ICU, especially for the nurses, it is a relevant topic for you, and it's a relevant on-ground problem as well as the understanding, because the first step of the solution of any problem is the understanding of the problem and the magnitude of the problem and the what level the intervention can be done. So burnout is having a 5 stages: honeymoon stage, balancing act, chronic symptoms, crisis stage, enmeshment stage. So from here the things starts. I'll discuss one by one subsequently. The honeymoon stage is where the people actually works out of their capacity. We'll discuss. Over the time period, you just try to balance and the chronic symptoms develop, and finally you give up over there. So technically, it is a balance between your dedication, energy when you join your medical career, in terms of you can help the population or the person in general. This work not only gives you professional satisfaction, this gives you opportunity to serve for the mankind, and you are having a certain skill which make you from the unique from the any other person. If suppose you are working in the ICU and you are trained for the airway management, you are trained for the CPR techniques, and it makes you an immense unique person from the so many a person in on this earth is not having that such skill, and that is a part of your profession. And the burnout is you are not able to manage, and as I told you, the exhaustion, depersonalization, cynicism, or your personal achievement. So job related stages which we talked about, actually a pathway from where the things start and end up with the burnout. So first is a honeymoon phase, shiny new phase, job satisfaction, your relatives, your all the friends, family circle feel very happy. Now you are in the healthcare. We are having so many problems. At least one contact is there so that we can help. We can seek the help, and you're also happy. You are helping to the people directly or indirectly, readily accepting responsibility in your workplace. I'll do this thing. I'll do this thing. Sustain energy level, optimism, compulsion to prove yourself. So you want to prove I can do so many things, and I can work for the a long shift or all these things, free flowing creativity, and you are all the time in the positivity. That is a honeymoon phase. The things, if I'll not say cycle will happen in the same way which I am describing it. It may keep on going over there, but if the things are not in the right direction, as I told you, either the raining and your umbrella is defective, so from there the onset of stress. Now you are having an inability to focus, irritability, lack of sleep, lack of social interaction, anxiety, avoidance of decision making, fatigue. Avoidance decision classically. Every time you require, just I'll ask my senior, I'll ask the team leader, should I do this thing? Should I do this thing? Patient is having a high temperature. Should I cold sponging them? Paracetamol SOS written by the physician. Should I give right now? Should I wait for this thing? Is where the clear cut things are there, but still you want to avoid the decision because later on the burden on the decision would be yours. Fatigue and forgetfulness. That is the first and foremost alarming. And from here, the condition is clearly reversible. If it is not addressed, now you are entering into the chronic stage. Lack of hobbies. Now, can you make out till the box 2? The things remain in your profit, everything related to the hospital only. Now, when box 3 come, the things come out from hospital to your personal life, entering into your personal and the physical life. Lack of hobbies, physical illness, chronic backache, headache, all the time, joint pain, muscular pain, procrastination. Procrastination is you keep on avoiding the things. Resentfulness. You just want to take the vengeance and all these things. Chronic exhaustion. Cynical attitude. नहीं होगा, ये सब बकवास है. Denial of problem. Feeling pressured or out of control. So if you see this box, both the things existing over there. Now the burnout. Burnout is your centric. Purely the burnout is the individual one. 1 or 2 would be a very generalized. Third is now individual factor comes into the play. Fourth is the same condition, same situation, same thing, same stress. A and B will be there. A may end up in the burnout, B may not be. So here, what are the classical sign symptoms one needs to understand? Feeling empty, ruminating over problem. Ruminating is all the time you're just thinking. You're not doing anything. Just keep on thinking some problem. Pessimistic outlook. Physical symptoms intensify. So physical symptoms started in the stage 3. Now it intensifies. Just you keep on running from one OPD to another OPD, from one doctor to another doctor, just to complaining your chest pain, your headache is not getting settled, your abdomen is not getting settled, your backache is not getting settled, and all these things. Please be careful. I'm not talking about the actual problem. If you are actually medical problem, that's okay. Here's the classical one is not actual medical problem. It is related to your overall work environment stress affecting your personal life and physical life also. Self-doubt. Sometimes you just you are not fit for the this profession. Social isolation. You want to keep yourself away. मैं किसी से बात नहीं करता, यहाँ पे भी मेरा अपना है. When I go to the hostel, I'll keep my room and all these things. I don't want to participate in any activity. Neglect of the personal needs, escapist activities. You don't escapic activities is you just escape from the what are the your routine job, what is your responsibility, you just escape it. And desire to drop out. Now you think सब छोड़ के चले जाता है. That is the burnout. And the fourth one which we are talking about, the actual burnout. From here you need to take a really action, and we'll see the what actions can. And lastly, habitual. Now you accept this thing. You accept मेरी life तो ऐसे ही चलेगी. And that actually goes into the chronic sadness, depression, burnout syndrome, chronic mental fatigue, chronic physical fatigue. And people themselves, as are the other people surrounding their friends and family, not able to understand the root cause started from the 1 to 2 kind of the complete personality change. Nobody think about this is the purely related to their working condition and their amount of stress that goes into the overall personality and the overall kind of this thing is. So it was a very gloomy picture. Don't get afraid. It will happen to everybody over there. Just the aim of this presentation is not making you very sad according to only this thing is once we know the flow over there, if everybody and everything, we can work upon it, we can recognize it. As I told you, if there is a problem and if you even don't know the problem, then the major problem. If you know the problem and you know the magnitude of the problem, then you know what needs to be done at what stage. So in general, the contribution, of course, you will find a little bit overlapping the ICU fatigue as well as this thing is, but in a higher amount. So schedule, floating, resources, patient family, difficult colleague, time pressure, workload, staff ratio, supervisors, lack of control, all these things can contribute. Now this slide action. Action is not from the nurse side. This action is advice to the leadership. So this slide is not meant for the individual. I'll go for the individual one. That is meant for those who are having a leadership role, like ICU nurse head or ICU director, ICU physician head or physician director, hospital superintendent, hospital medical director, all these things who are in the clinical and operational responsibility. What action? Measure burnout, add nurse burnout as a performance measure. Be the change. The entire purpose of leadership is to create the culture so that it can be prevented. Cultivate leaders. So it is for as I told you, leadership, not the individual person who is suffering. It is more for say, for example, ICU nurse in charge. They should cultivate leaders. That means they should really cultivate the leaders rather than a autocratic way. Just I'm saying this thing has to be done, rather than a leader, so that people will take their responsibility. And how you really know if somebody says no, I am very liberal and this thing is so simple clue over there. If your unit can run without you, you have done your job. So if you really think I created so many leaders in my system, when you are not there, your unit will work in the same way. That means you are successful. And if you see when I am not there, then everything will be go hayway. This unit can't be run by me. I am a most important person. Then you are failed on this point. Connect, facilitate a collaborative and safe forum. Align goal. create opportunity for innovation and share accountability. So it is not, say for example, if pressure injuries happen, so it is not the one person fault over there. The whole system, there will be a shared responsibility over there. It is a individual, your performance of the shift nurse, your processes are there or not, who is gauging the process, what are the problem, what is the reporting system, are their reporting system, gadgets are enough for them or not, their knowledge is enough for them or not. So all these things we need to understand. And finally, reward and recognize. If somebody, the human nature here, the people, right from the ancient world, people always run behind the rewards and recognize. So question potential solution of burnout are all accept. I expect now people should participate. Is change the job solution, change the workplace solution, take the break, do partial work of your assignment. So change the job, all these things, workplace, all are solution. But doing your job partially is not solution. So change are there. Now individually. So individually, they have to work upon it. As I told you, their defensive mechanism, their thought process, and they has to be very optimistic. So the individual person try to manage the things in their capacity from their mental status, develop from optimism has to be there, from pessimism to go for the optimism. And of course, here the teamwork is very, very important. Nobody can do especially the critical care is a completely teamwork. There is no individual role for the overall running your unit. So you have to work as a team. And once somebody recognize, you join your hands to one to the another person. As I told you, ICU fatigue reasonably objective, you can measure. Burnout individual factor comes into the play. Same stress, same environment, one may turn out to burnout, another may cope up over there. So it's your overall teamwork, all the things joined and together, and then the work would be your enjoying place rather than you're afraid of coming to the ICU for the duty. Thank you and wish you Happy New Year to all our participants.
Thank you, sir, for the wonderful talk. And if anyone has any doubt, they can put it in the chat box or raise hand.
So
So
somebody,
as we saw from the lecture, sorry, sir, please.
yes, Dr. Shakya, just I wanted to your view till our any
So
colleague.
as we saw from the lecture, and you realized how important addressing an alarm is, not only for the patient, but rather when you start doing that more effectively, you realize you are addressing the alarm yourself, and somewhere the fatigue also goes off. I would say, if not purely go off, but at least it is delayed, or you know how to handle the situation well. That's when, again, as sir told, the interest comes in, you are well trained, and fatigue is not an issue for you at that point of time. And very importantly, burnout you should recognize among yourself or in your colleague, because that can lead to severe consequences. And definitely you can help everyone if you recognize and have a discussion, healthy discussion, I would say, and avoid burnout among colleagues also. Sir, you wanted to tell something?
Uh, Only important thing which I notice, which is a high time now for our intensive care, is addressing of the appropriate alarming system. Most of the our ICU are noisy to just alarming all the time. So I would request all the participant at least try to customize the alarm. That is the first step over there. Just customize the alarm. Just tailor accordingly. So whenever there is alarm, you have to think of, yes, there is alarm. Then we'll come to the whether the response timely and the appropriately actionable. That's the secondary. As if now people accept this norm, ICU must be now noisy only. Ventilator should keep on alarming. NIV start with the alarm only. So that culture has to be changed right now at this moment, because JCI make the this standard very recently, last 3 4 years, and they recognize when they make the standard, they recognize there is a potential here to scope of improvement over there. And of course our Indian accreditation little bit lag behind that. It is very well expected NABH will also include this in the coming years. So forget about the accreditation or NABH. Technically, as if now, we just pledge from this thing, from this lecture. Whenever there is alarm, at least we understand it is alarm. It is not the norm of the ICU. That's the simplest thing, and we can go step by step. Related to the ICU fatigue and burnout, as if now we really don't want to any of our ICU colleague goes into the burnout state, should be addressed early in the phase. There the enter individual variation would be there. We are working as a team. A person may be good at the recognition, B person may be good at the documentation, C person is outwardly or extrovert to reporting all these things. So we need to accept inter individual variation. Simultaneously draw a certain line to keep our ICU standard intact. This is the bare minimum, like a closed loop communication in the crisis. The action required, the ACLS stage where we are encountering. All these things has to be cultivated, and beyond that, everybody is a little bit different. We have to accept the variation among the individual.
Very well said, sir. And so we don't have any such doubts on the chat box.
And lastly, just for a minute also, anybody wants to, because now almost I'm completing in the next 1.5 months remain for my tenure. Anybody wants to a specific topic for coming step in session, please let me know. Or they can write now, they can type in the chat box for the next maybe 4 5 topics I'll cover in my tenure. So any specific topic, they can write it right now. Any suggestion for the subsequent 4 5 lecture? I purposely selected myself for today's lecture because it's the 1st January. I want to wish everybody for the Happy New Year, and simultaneously wanted to really our shows goes on without affecting the night's eve celebration of all these things. And Dr. Shakya was with me for the so many years, so that I took the liberty to engage him today's session.
Thank you, sir. Thank you, sir. So we'll wrap up the session, sir, in case.
I don't find any query in the chat box, so I think we can close.